Thank you very much. Could everybody be back in the rooms? We're starting the session now. Okay, we're starting off this session today. The reason why this session was positioned at this level in the program was that after we heard everybody give us their opinions on where the global health is going, how the ecosystem needs to be corrected, do this, do that, you know, we'll have this, we have to do this. In the end, somebody's got to pay for it. And we had the universal health coverage where we discussed, yes, we have to pay for it. And we've got to pay whatever means we do with it, to taxation, to duties for this, however we bring that financial security. But now comes the most important, that you and me always ask this question, but how much do we pay for it? What's the cost of this? So this is opening up, this is about including patients, so it's opening up health economics, HTA, value-based healthcare to patient partnership. We have been opening up everything from regulation to physician and nurses education. We've been talking about through the value chain to self-care. Now's the time to see how we can open up this session or this particular area of health economics. As I said, Tessa is here with us. Tessa's General wrote a very nice quote that health is a political choice and politics is a continuous struggle for power amongst competing interests. And in low and middle income countries, I think this happens. My growing up, we always had this situation where the president would say, yes, I've got $50 million to expend. How do I divide it? And there are 5 ministers sitting there. Says, okay, divide it by 5, everybody. But then the Minister for Foreign Affairs and Defense gets up and whispers to the ear of the President, but President, our neighbors are looking at us with a very poor light. I think defense should have more. The guy says, okay, I will give you another 50, so we'll split it. You have this burden. And just when they think they're settled down and the poor health minister says, okay, that's my lot, what I get. Then gets up the Minister for Internal Security, who whispers in the ear of the President, Mr. President, all these 5 are there to get you. He says, right, I am putting all my money on internal security. The Secret Service, police, check the police state. So this is what is happening. The political competing interests, and they have to balance it. Either you put money on transport or education, and that. But irrespective of where it goes, Henry Buckley has always said that mistakes are made and costly. Somebody must pay for it, and let's not be us. So today we have a very elite and high, powerful panel to discuss with this. First, we've got Dr. Paula Jabbar, who comes from the Outcomes Research Team at the International Consortium for Health Outcome Measurement, ICHOM. ICHOM, as you know, was set up or has as its guru Professor Michael Porter, who is the textbook guru for all MBAs, yeah? When you look at his competing interests. So he came up with that beautiful equation. He simplified it, knowing how easy is it simplifying things. And like Hans Rosling, he kind of takes some complex issues and then he tries to visualize them. And he just said that value-based healthcare can be just said that the outcomes that are preferred and valued by patients divided by cost. And then he said very nicely, he says, look, you can't reduce costs below zero, but you can improve outcomes to infinity. So don't concentrate on the low part, look at the other. Then the most important speaker for me, I think, for this partisan, but also from point of view of that when Prime Minister Tony Blair got into power in the UK, the first thing he did was set up NICE, the National Institute of Health and Clinical Excellence. And the reason for setting up NICE was on several points, that he did not want the NHS or the National Health Service to be bogged down with judicial reviews, questioning pounds, pence, shillings, and health economics, time and time, every time. And he made sure that he set up NICE as a respected, independent, highly professional, and approachable and easily accessible for patients institution who will look at the health economics part of it, give advice to the government about this can be paid for, this can't be paid for, or let's discuss this further. Because NICE was always looking for that, what does society value? So the societal point has always remained there. It's not entirely societal. What are we ready to pay for something? So we have got Dr. Dalia Dawoud here. She's the Associate Director of Science and Policy Research at the National Institute of Clinical Excellence. But also Dr. Dalia, please follow her work on LinkedIn and others, her position papers on health economics. Everything from biosimilars, especially I was talking to Dr. Sausan there, that look, this is really important for us. Our Personalized Cancer Care Alliance has been saying we should have monoclonal antibodies, personalized treatments available to us, and also we're talking to Ross and Biomarine and others. They say we should have this in, but Dr. Dalia worked that out way back. I think it's almost 5-10 years ago, but firstly biosimilars in the cancer space, but then the immunotherapies, but now furthermore. So Dr. Dalia will swing, and then from the patient perspective and from the Latin American side, one of the guest speakers I think I've always enjoyed, Cardozo, who's the executive director of the Colombian Federation of Rare Diseases, in that Colombia has been pioneering HTA use, and it's an academic, societal, patient initiative. But more importantly, it's the rare disease element. You find that when HTA comes to be applied into some areas, then we have challenges. For large-scale NCDs, you have various treatments. You know, for one single treatment, you have simple things like invest in walking, cycling pathways. On the other side, you might have beta blockers or something else. So you have choices there. But with HTA in rare diseases and not. So Diego has been very good in that. He's been engaged with that. He has got an overview. Our last speaker will be Orajitt. Orajitt is a board member, and Orajitt is from the Heart to Heart Foundation. But more importantly, Orajitt is linked in heavily into HTAP, which the NICE administration and others call the rising star of the East. It's almost a mirror of NICE in Thai and Asia Pacific, where they've taken upon themselves to spread the health technology message, economics, and train people. It's like your party stroke regulatory agency that's helped out a lot. So Orajitt will talk about that. And then could I now welcome you all onto stage, please?
Thank you.
I'll open the floor now to Dr. Paula Jabber. You go ahead, yes, thank you.
Hello, and thank you very much for the invitation to be here. I had some, there we are. Okay. So, as mentioned, I'm here representing ICHOM, the International Consortium for Health Outcomes Measurement. And what we do is that we work on value-based healthcare. We measure patient-centered outcomes to improve quality of care and to improve patient outcomes, but also the conditions within the clinic, the hospital, or any healthcare provider that implements our sets. So this session is focused on health economics, so I'll try to focus on that aspect. But as this is a patient-centered event, I really want to focus as well on the importance of keeping that at the heart of anything in healthcare services, and how that then indirectly will improve health economics and the finances of any institution providing healthcare. So just to start, can we go to the next slide, please? Thank you. So ICHOM, just to give a brief context of what ICHOM is, where it comes from. So as mentioned, Michael Porter from Harvard Business School, Stefan Larsson from BCG, and Martin Ingvar from the Carolina Institute, about 10 years ago, decided to found this organization, because what they realized was that there was a lack when providing healthcare services. Firstly, this was founded in the US, so the initial thought came from the US, but quickly they realized that this was an issue going on worldwide, was that there was a lack of measurement of health outcomes, not only from a patient perspective, but in general. So the initial problem is, if we're not measuring outcomes that go beyond overall survival, mortality, morbidity, then we don't have information on what's really going on with patients. We don't have information on what's affecting the patient, how is the patient living their treatment, living their experience with this disease, whether that's an acute disease, chronic disease, rare disease, or anything. So if we're not measuring, then it's hard to define results. So those who are measuring, they're measuring very, as I mentioned, very few results, mortality, morbidity, but that doesn't give us enough information to see where the problem is. So allow change. So we have patients who are receiving care but not getting the results that they want, and we don't know where to start to make change. And then those who are measuring results or are measuring outcomes aren't doing it in a standardized way, so that doesn't allow us to compare outcomes or to compare the data that's being collected. So that also makes, it's not counterproductive, but it makes the measurement of result slightly inefficient. And finally, the focus was always, when measuring outcomes, is always on the process, not so much on the patient perspective. So we think that the change that we have to make comes from the protocols within the hospital or within the clinic, protocols of surgery, guidelines that we're using, but actually at the end of the day, we're not really seeing what the patient needs. Next slide, please. So on that, with those thoughts, they came up with the concept of, well, this equation that, and I should say, I'm not a health economist by training, but this is a very easy equation that allowed me, when I started working in this field, to understand. So when we look at patient-centered outcomes, and we talk about value, so as I said, we work on value-based healthcare. We don't think of value as in how much money is it bringing us, how much profit is a hospital making. Value is focused more on what health outcomes are being measured, and then I'm trying to summarize this equation, but essentially we focus, as I mentioned here, on the value, on the health outcomes, and that will define the cost. not the amount of surgeries or the amount of medicines that we're providing. Rather, what are we measuring? What are we focusing on? And is that the patient perspective? And from there will come the value. So from there will come the benefit, not only for the patients, but also for the hospitals in terms of investment and in terms of how much they're paying for whatever healthcare services they're providing. Next slide, please. So, so to do this, ICHOM looks at the global burden of disease and says, okay, well, which diseases are most prevalent? Which diseases are most affecting patients worldwide? And then from there, about 10 years ago, we started creating sets, which are, in a very, very simplified form, lists of measurements that we have to make and lists of outcomes that we want to look at for each disease specifically and say, okay, what is it that a patient living with this disease is experiencing? What is it that we need to measure to see if the treatment is working and to see if the patient is actually getting benefit out of it? Because as I said when I started, that's really what we want to focus on, and that's what ICHOM focuses on. What does the patient need? What matters to the patient? And then from there, all the benefits will come. So this is, and I made a small mistake, we have 45 sets that have been completed, and we're currently working on more sets. We've just launched the development of a set for obesity. So we have all these sets for all these different diseases that are so different from each other. And what we learn from it is that each disease is very different, and we need to speak to patients directly, and we need to define very specifically what a patient with, for example, diabetes is suffering, and what a patient with lung cancer is suffering from, and what their experience is. And then from that, we can see what we need to measure, and then what steps to take. So just to give a brief overview of some of the impact that these sets have had. Currently in Germany, more than 180 clinics are implementing our localized prostate cancer set. So almost, I'm not sure about the percentage, but almost every clinic in Germany that treats patients with prostate cancer will use our set. And from there, they'll be certified by the German Cancer Society on quality of care. Because we've set a standard to define what matters to patients, and the results have been very positive throughout. There's a clinic in Mexico City that uses the diabetes set, and they've reported on their results. And talking about economy, one of the results that's most impressive is that they realized that when they implemented our set and started measuring outcomes, and defining everything from the patient perspective and systematized it that way, they were reducing cost by over $7,000 per patient per year, which is huge. So again, looking at the patient perspective will indirectly bring benefits, not only to the patient, but also to the institution. And as a final example, which is a really big example for us, is the Glue Care Center in Dubai, who also focus on diabetes, and they were certified by us last year because they do outstanding work with value-based healthcare and have had also amazing results economically and in patient results. So thank you very much.
Thank you very much for that, Paula. And as you said, this is that huge thing that what is that value of our healthcare brings to us, and how do we, as a society, appreciate. Now, our next speaker will be Dr. Dalia Dawoud, who's the Associate Director of Research at NICE. And Dr. Dalia will look at the insights and position of patient participation in HTA, and how why it's a successful in NHS, and what is NICE doing to encourage that, and how can we take those lessons globally. Thank you. Dalia?
Thanks a lot, Kawaldip, for the introduction, and thanks for the invitation to be with you today. As Kawaldip said, I will be giving you some insight into patient and public involvement at NICE in our decision-making specifically. So on the next slides, just my disclaimers. So if we can move to the next slide. And the next. Thank you. So NICE, or National Institute for Health and Care Excellence, as Kawaldip mentioned in the introduction, we are considered a health technology assessment agency for England specifically. Other countries within the UK have their own HTA agencies. So Scotland has its own SMC, which is the HTA agency for Scotland. Wales has another one, and Northern Ireland has another one. And NICE was established in 1999, and essentially it was established to develop both clinical guidelines, but also to look at assessment of new medicines that are being introduced in the National Health Service. And the main reason was really, as Kawaldip said, first of all, to ensure access to patient is equitable across the UK or across England specifically, and there's not what we call a postcode lottery, so that medicine access is not really decided based on where you're based in the country, but care is the same everywhere based on national guidance that applies across all the NHS. And NICE has currently over 700 staff members in London and Manchester, so 2 offices. So we've grown massively since the start of the organization, which was really very small at the very start. NICE doesn't only do health technology assessment of medicines, but we also are responsible for developing clinical guidelines for the National Health Service, also public health, social care guidelines, and also we do assessment or evaluation, health technology evaluation of diagnostics, interventional procedures, medical devices, and most recently digital technologies as well. So we do assess the new apps, for example, that are used by patients as well. So next slide, please. And NICE has a number of core principles, and really patient engagement is at the core of our principles. And I picked up here that 2 core principles, principle 4 and 5, really makes it clearly how we are very keen on taking into account the advice and experience of people using the services and their carers and or advocates in general, healthcare professionals, commissioners, providers, and the public. So it's not only patient involvement as well, it's patients and the public, and all who are really being addressed by our clinical guidance. We also ensure that we offer people who are interested in the topic the opportunity to comment and to influence the recommendations. And that's through transparency in our working and public consultation on many of our outputs at various stages of the guidance producing process. So on the next slide, we can see who we involve actually. So we have key patient and public stakeholders that we involve. We involve lay members, so our committees that does the health technology assessment have usually 2 lay people for each appraisal committee that are members of the committee. We also invite national charities and patient organizations to comment or draft recommendations and provide submissions during the assessment process. Patient experts are also attending for whenever there's a medicine for a specific condition that's being appraised. We usually have patient experts who have the condition and can give that patient perspective and explain how the new medicine, for example, can change their care. So these are individual patients or carers that attend the actual appraisal committee meeting and provide personal statements. But also, as I said, the public, anyone can comment on our draft recommendations. So once there is a recommendation, before the guidance is published, there is a public consultation, and anyone from the public can actually submit their comments on the draft recommendations. So next slide, please. So how we do that, we've actually grown that function within NICE, if you like, that's responsible for patient public involvement to become a whole team that's really focused on engagement, public engagement in general. And we have a number of potential routes for engagement. So as I said, we can have patient organizational submissions from patient organizations. We can have patients submitting their individual statements. But also we can have surveys of patients that are affected by certain conditions. And also there is a lot of pre-meeting engagement activity. So at the various stages of the appraisal of a new medicine, we do invite submissions from patients and by attendance at committee meetings, as I mentioned as well. So in the next slide, we can see the timeline, for example. This is an example of from the appraisal of a medicine that could be a medicine for a rare disease or for more prevalent conditions, so highly specialized technologies, as we call them, or technology appraisals. This is slightly different now, as we have just been making changes to our process timelines. So from the left to right, you can see as the process of appraisal progresses, for each point, there is potential involvement from the public and the patient, starting from even the topic selection, what medicines are we appraising or looking at or assessing, how we identify and select these. So there are lay members that are involved in the decision-making panel, and also during the initial scoping phase, how we are going to compare this drug versus what outcomes are we going to look at. There is also patient organizations input into the scoping phase through attending at scoping consultation or attending at scoping workshops or providing their comments during scoping consultations. And then when we invite the company to submit its evidence, there's also evidence submission that's invited from patient experts, and they can provide written statements as well, as I mentioned before. Even at committee meetings, our committee meetings are actually open to the public, so anyone, and actually now they have gone virtual, so people from other countries tend to register to observe our committee meetings and see how the appraisal is run. And that really gives that transparency and confidence in how decision-making has been made. And then sometimes some topics finish at the first committee, others would go beyond that, and if there is no recommendation, if you like, if we are not don't approve a medicine, there is that potential for a consultation and submissions from that where we can, like, if you like, this decision can be challenged based on submissions as well. So, and there's the potential for appeal where also patient organizations can also appeal decisions that NICE has made. So literally, we try to involve patients and the public all the way through the whole process. So next slide, please. And the evidence submission, usually, we know that some patient organizations are much more stronger and bigger and more experienced in engaging with NICE, but for other disease areas, it's not that much. So we do offer support during the whole process. So we ask people to provide us the submission that covers the experience of living with the condition, how it affects their life, how it affects specifically quality of life of the patients, carers, and their families, and how the new treatment or technology can affect their condition, and what are the advantages and disadvantages. And then the organization that's making the submission should also make it clear how the information was gathered from the patient to ensure representation across. And there is support also to organizations to be able to provide these evidence submissions. And on the next slide, I have put what sort of support that we give from the public involvement team at NICE at these stages. So we have specific support to different groups, so for patient and carer organizations, and for patient experts during the committee meetings, and for lay members who are members of the committee. So for all of them, there is a named contact within NICE, within the patient public involvement team, who is an advisor that can help them all along the process. And at the very end, there's an exit survey also for the process to get feedback and to understand how the process of involvement has been for them and how we can improve on it. And then in between, it's tailored to what role they are playing. So whether they are a patient organization that will prepare an evidence submission, we help them by providing forms, templates, guidance, monthly induction as well for them to understand how they can engage with NICE and engage effectively in the process. And for patient experts who are coming to talk for a specific meeting or on behalf of their patient group, if you like, we also offer to read and comment on any draft statements they are preparing and help them. We know it's emotionally also very difficult to come to these meetings and start talking about your own experience, or if you are a carer on your child's experience. So we usually offer support as well for them, and making it much easier and accessible for them to be present and available at meetings. And for the lay members on our committee who are members of the committee, there's also induction and training and update about modules and toolkits to help them to be effective members of the HTA Appraisal Committee. So that's in a nutshell, really, what we have done, and we've grown so massively. So we've started small, but we have really grown so massively, and I'm really delighted that NICE is becoming really a flagship in terms of patient and public involvement, specifically across the world, and sharing that experience with every new HTA agency that's just starting and having issues of engaging patients and the public. Thank you so much.
Thank you very much, Dalia. I think the thing that was coming through was how, from day one, I think some background I'll give to you, that when the NHS was set up in 1948, the then minister had said that he wants to have such a level of public involvement in it that if there was a bedpan, when nurses used to bring bedpans to your bed, if that bedpan falls in a ward in a hospital in Wales, which is a very far away, hilly country, remote, from an English perspective, you can see why we're saying, because they also speak their own language, Welsh. So he says if a bedpan falls there, the sound it makes should be heard in Westminster, which is in where the Parliament is, where King Charles just got the coronation was. So that's a level of public involvement and reach it should be. And thank you, Dalia, then. I think we're still keeping that principle of public engagement. Then. Now I'll bring Diego Cardozo to speak. I think Diego comes from a continent which is slowly coming up very powerfully. It's developing in high speed. It's double-digit economic growth, still in current, from current economic environment. But more importantly, this economic development is reflecting in healthcare systems and the adoption of health technologies and even economic technologies. And Diego, coming from the rare disease community, has that added insight, and he will lay out what are the learnings and recommendations from a survey they carried out with FECOER in 12 countries in Latin America with patient and public involvement in HTA. So these are the kind of surveys we would like to share with Tessa Richards here. So Tessa, expect a copy sent to you of the survey they carried out, patient enrollment in HTA, I think, ready-made. As I'm sure you said, you don't guarantee pre-publications, but we'll submit and hope. Over to you, Diego.
Thank you. I want to thank to IAPO, to you, Kawaldip, and to the board members for the opportunity. For me, it's important to be here learning so much, and for us it's very important to have the opportunity to share our experiences from LATAM, from rare diseases community from LATAM. First, I want to share with you that I am a rare disease patient. I was diagnosed with pulmonary hypertension more than 30 years ago. This is the reason why I am a patient advocate. I am the executive director of the Colombian Federation of Rare Diseases. We work with 46 organizations in Colombia for the inclusion, integration, and improve the conditions of people with rare diseases, and we are working in a network with different federations from Latin America in a platform that is ERCAL, Enfermedades Raras en el Caribe y América Latina, rare diseases in Caribbean and Latin America. I want to give a context. Rare diseases now in the world are more than 9,000 rare diseases identified, and we estimate that there are more than 200 million people that are affected with rare diseases. There is a big population. They are rare, but we are so many people. We have a very reduced availability of orphan drugs. Less than 10% of rare diseases have availability of any therapy. We have a challenge, a big challenge, in order to promote the access to the different technologies in order to improve the conditions, the well-being and health of people that are affected with rare diseases. For this reason, it's very important for us to promote the access and to work in issues like health technology assessment, taking into account, next slide, please, taking into account that rare diseases, in rare diseases, we faces some challenges that are very important. I want to share with you some information that we presented in the World Orphan Drug Congress in Barcelona last year. We work with Veronica Lopez, who is our advisor. She's part of HTA involvement interest group that works in all the issues regarding the HTA and promoting the participation of people and citizens in HTA. HTA in rare diseases is a challenge because small population sizes, so incomplete understanding of rare disorders. We have limited evidence, a scarce of evidence in rare diseases. For this reason, it's very important the participation of patients in the health technology assessment. We have a limited clinical and quality of life evidence. Cost-effective models do not apply in rare diseases because most of the health technologies are very expensive. Rare diseases are heterogeneous conditions and are very diverse. We have high rate of children affected, and they are severely disabling of life-threatening nature of many of these conditions. We want to share with you some findings that we have from the short survey that we do in Latin America. Next slide, please. We made a short survey. We have next slide, please. We received responses from 8 countries: Argentina, Brazil, Chile, Colombia, Dominican Republic, Ecuador, Mexico, and Peru. We can find that we only have 2 countries from them that have a formal process for participation, patient and public participation in HTA. There are countries like Chile, for example, Dominican Republic and Ecuador that do not have formal process for the public involvement. And we have some countries like Colombia, for example, Mexico and Peru that have semi-formal process. We are in progress in order to implement some guidelines that are provided in some cases by the health technology agencies in our countries. We have some useful information regarding the special considerations for HTA in rare diseases, taking into account that rare diseases have to include differential criteria in order to evaluate the different technologies. For example, in Argentina, Brazil, Colombia, and Peru, we can find that there are differential criteria in order to assess the different technologies. This is an important advance for us. I want to share, next slide, please, some barriers about the public and patient participation or involvement in HTA. We can find that one of the main barriers is that there is a lack of formalized processes in order to involve the people in HTA. In the second place, we can find that patient representatives are unaware of ways to participate in the process. We have to work so much on training our patient experts and our leaders of rare diseases organization in order to reach the expected role in this assessment. We can find also that patient representatives are unequipped and trained to participate in HTA assessments, and we have to work in the communication and in the interaction between the HTA agencies and the rare diseases organization in order to promote this participation. There is another issue that is very important, and that is we don't have enough publications about the participation of patients in the health technology assessment. It will be very useful in order to promote best practices in the different countries in Latin America. This is a snapshot. Next slide, please. I want to share with you the ways in which patients and public are involved in Latin America. These are the different stages of the health technology assessment process. We can see that the stage in which there are more participation from the patients is in identifying, proposing, prioritizing topics for assessment. There is a good participation sharing new evidence, including patient experience data. This is very important because the patient is the expert in the patient journey. The patient is the expert to provide the useful information in order to inform what are the expected results from the implementation of any technology, health technology. This is very important. Making recommendation is a good participation there. Identifying clinical outcomes, and we can find also that there is a lack of participation in writing reports and analyzing data, maybe because these stages are very technical, but we have to promote the participation of the people in these stages. This is the idea. Brazil is one of the case study for us. Brazil has very good advances. They have very important guidelines in order to promote the patient and public involvement in Latin America. They have been working so much with CONITEC, that is the health technology agency in this country. They have additional activities, for example, plain language summaries of recommendation reports. They have guidelines for patients' involvement. They have informative video conferences. They have many resources that provide to the patients and organizations in order to promote a good role in the health technology assessment. But they have important suggestions in order to improve the process. For example, transparency in the relations between among the stakeholders, capacity building for HTA, just as an equity in order to patients and public have the same rights as other stakeholders to participate. This is regarding Brazil. That is a good case study in Latin America. I want to share with you also about Colombia. Colombia is pioneer in Latin America in the participation, but we also have some challenges. We have a patient participation guide that we have built with the health technology agency in Colombia. This guide establishes objectives and guidelines for the interaction of patients and patient organizations with the stakeholders of the HTA processes, and defines the participation mechanisms and scenarios. We also have had different possibilities to be trained in order to play a good role in the different assessments. We have also to work more or to move forward in order to increase the leaders that have the capacity to participate in these evaluations, in these assessments. Some recommendations to finish. I think Latin America needs to formalize a mechanism for public and patient participation in HTA, detailing a clear methodology that includes objectives, a scope, and the results that are expected from the process. The participations of patients and citizens in HTA must take place in all the activities, in all the stages. It's very important. Training activities should be promoted with different tools based in understandable language, because it's very important that the terms are not technical. We don't want that the patients become clinical experts. Is not the idea. We want that the patients can share their experience from the day-over-day journey. Finally, next slide, please. Oh, sorry, I forgot to. Okay. Brazil, Colombia.
Recap.
I was speaking, and I forgot. Okay, Colombia. Next slide. Final slide.
Thailand.
Final. Oh, sorry. Patient and public involvement must be documented. It's very important in order to share the best practices, in order to reduce the gaps among the countries. We tried to find some information about the participation of public and patient in HTA in Latin America, and we didn't find some articles about that, and it was I think that this is a good opportunity to work on that. And finally, HTA agencies in each country should promote interaction with patients and leaders of patient organizations. It's important to connect the HTA agencies with the reality, with the patient journey, and it's important that leaders of rare diseases organizations and patient experts can be connected and understand what is the importance or what is the objective that we pursue with the health technology assessment, what is the expected role in this process. That's all. Thank you.
Thank you very much, Diego. I think that was what we needed, to know that patient engagement is heavy, and Diego is our partners in Latin America. And I think Paloma is here as well. She's from Peru, and we've been discussing this, how to take this forward in Latin America in more engaging ways. It's a model that you've set, and you've really done a high piece of study. I think this is where that patient co-production was involved. I know Dr. Lopez engaged you guys intensively in all the studies and publications, and that's a criteria I think Dr. Tessa Richards has been claiming as authors should bring in that patient engagement element. Now next to the rising star in the East.
Not me.
This is, yes, this is high accolade that NICE UK paid to Thailand's HTA program. And it was paid at when they had conference at the Thai University, the Prince Maidul, and they launched a book. Do look at the book as well, yeah, The Rising Star in the East, HTA, HTAP. You'll find great praise. Also, I would like to praise Thailand for that it was amongst the first countries way back to introduce universal health coverage under the 30 baht. 30 baht, the Thai currency was 30 baht. NICE obviously increased, but it was a very good, bold move to bring it on, and it's a community engagement. Orajitt, to you to now keep the star shining.
Yeah, thank you, Kawaldip. And thank you for giving me a chance to speak in this session. Yes, I think you understand the HTA or HTAP Thailand very well. And so glad to speak about the participation in the HTA Thailand or HTAP Thailand this time. And since yesterday and this morning session, and even our speaker here, is confirmed me about what I'm going to speak about the patient participation in HTA. Slide. Okay, next slide, please. Yes. What I'm going to speak is first we talk about how to hold partner accountable in the universal health coverage scheme. Since it's already in the National Health Security Act, so we have patient participation according to the law. And the voice talks about the voice of people, patient in the system, because that is some kind of, you have to drive the law into action, into patient involvement. That is not easy, but not difficult, because we also have people movement to fight for the national health security system in the beginning, to fight for the national health security law, and those people, the NGO, they also try to involve in the management. They sit in the NHSO board, also 5 of them. I will talk later. And then talk about the history of HTA in Thailand, how to apply HTA in Thailand, and how to involve the patient in the structure, the governance structure, and the current participation, patient participation, and also there are some gap, lesson, and future direction for patient participation. It's not mean that everything is perfect. And for the how to hold partner accountable in USC, I think most of us already talk about it's important to protect the rights of patients or people to participate in the health security system, and we have to make them active and allow their voice to be heard and transform into policy and implementation. And the HTA is one tool to make it possible. And also the strong partnership between our partners. We have to first share objective and commitment. I think everyone know we share agenda together. Second, we have more dialogue and negotiation. As I said this morning, we have a patient and people organization alliance forum to talk and dialogue and to have agenda to develop, and then mutual benefit, because we already agree between us, and the building and maintain the commitment, because they will follow whether you have done or not, and then they will involve in the process as well. And also after that we have policy proposal development from the dialogue, from the voice, and from what we have talking about. And this is the next please. This is what patient organization, what type of patient organization we work with. We, according to the National Health Security Act, we have 9 people organization, including patient, in the act that we will work with. So the first is HIV and NCD patient network. Second is youth and women network. Third is elderly and handicapped network. Fourth is worker and farmer network. Fifth is marginal and slum network. Maybe it's 9 already, because I have count is not properly. But this network is in the law. So we have representatives from this network, 9 of them, and then we will select 5 to sit in the National Health Security Board. So they can represent almost the people network. And also have patient support center. This one, as I think I told you on NEDA about the patient complaint center, is independent and they are network. So they work very well also with the other people network or patient network. And also, this is same people. The former one, they work closely with the healthcare center, with the professional. And the last one is people complaint center. They work closely with the patient and NGO and to solve their problem when they have problem of medical treatment. And this is high-cost chronic patient network. Also, mainly it's the heart patient network, diabetes network, cancer patient, renal patient. You can see the renal patient network. By that time, they fight for the benefit package to put in the system. This group, they in front of the government house. They fight for that. They go to the government house. They try to meet the prime minister. And these two, the renal patient network, that two in the front already passed away because of the renal disease. And disability network also, and HIV, they come to our office and have dialogue and talk about their want. So voice of people, as I said, there are many channels according to the law, according to the system, and according to the civil society. And the number 6, they involve in the health technology assessment, the HTA, HITAP Thailand, also to inform the policy decision. So now I talk about the short history of HTA in Thailand. This already present in our Asia Pacific Patient Congress, and it's good that because we have so many patient organization and they alert and they know that, oh, I should involve in the NHA process, HTA process. The Universal Health Coverage Scheme we established in 2002. And after that, 2 years later, we have HTA to help to evaluate for the renal replacement treatment and also for the end state of the renal disease. And next year also, following year, we have the peritoneal dialysis first because under the Universal Health Program, we have the policy that PD first. We will not focus in the hemodialysis. We focus in the peritoneal dialysis that you can do yourself. Okay. Okay. So I will jump. And then later we have established HITAP. As you said, there's a licensing site in the east. And the HITAP will also handle for the HTA process, and they develop for they inform the benefit package and the national list of essential medicine after that. This I can say, I will skip because it's already mentioned, but I have to stress that HTA in Thailand plays an important part in healthcare coverage decision as the country level since 2009. And the how to application HTA application in Thailand on the left. Next slide, please. Next slide. Sorry, I forgot to tell you HTA application in Thailand. Next one. Next, please. They will concern about cost effectiveness, concern about budget impact, concern about feasibility, and mainly they will focus in the pharmaceutical product to evaluate even there is cost effectiveness value threshold and in the system, and also concern with vaccine product and non-pharmaceutical and non-vaccine product and public policy evaluation. They work closely with the National List of Essential Medicine, National List of Essential Vaccine, and benefit package of the USC, Universal Health Coverage. For the governance, they work closely with the Universal Coverage Package and also with the list of National List of Essential Medicine. Next, please, to the process, to the next, please. Current patient participation, okay, this one. The process, you can see that there are 6 processes. And the patient, talking about the patient participation, they will participate in the first and in the third and in the 6th process that involve patient participation. That means the first one, when they have topic nomination, they will involve the civil society and patient to discuss and looking for what is the topic from their voice, from their needs. And for the third conducting study, they will involve the patient organization and discuss how about to study and research, and it's consultation. And number 6, they also implement and evaluate the impact. A little bit about number 1 that they're talking, you can see that they have stakeholder involved, and you can see next, you can see that they have civil group on the left, the red one, civic group, the patient network, and lay citizen to discuss and find out the topic to discuss. But actually, they, as I said, they have mechanism among them. They already discuss what is the topic, what they need, what they want to voice out, and then from that topic, they put it in the HTA process. So, and the next one, on the third, I have 1 minute, please. And number three, next slide. And then after that, they're conducting study. So this is a process. Also, they involve the stakeholder, including the patient, to talk about the topic nomination, talk about the topic selection, and then they doing research and also have decision making. From the research, they have forum, and maybe after that, I have example after that forum. Just 2 slides, please. And the implementation and impact is make me breast harder. Implementation and impact evaluation, that is action. After you nominate the topic, after you have research, and then they have implementation and they evaluate their impact. So the last one, lesson and future direction for the participation. You can see that maybe, I don't know whether it's the same like you, we have the limited patient network involvement at the moment. They don't know about HTA, they interest what they want, and they're not much aware, they have lack awareness among them, and lack information and understanding in the society and patient group, how they have to work together, and lack of systematic report and data collection mechanism, and the social patient group has personal interest. I just want this, but sometimes they're not mind the research, not mind the evaluation, and research input mainly comes from clinician. You agree, right? Come from clinician. So what we want to do, the next step later, we should advocate society and patient group to think big and start based on opportunity, because there are opportunity, but sometimes they don't know, and sometimes they can't find it, and cultivate the strong patient network, because as I told you, we have patient alliance, but some weak, some strong, and they are not work together as well, and have strategy to strengthen and sustain patient participation in HTA. This we also talking, how to involve them in a systematically and more systematically governing structure and system and people. At last, we will build long-term technical and system capacity among patient community. Okay, please help together and we can go to the same direction. Thank you.
Thank you, Orajitt. Okay. Right, to speed up things so that some of us have to catch flights. Dalia, what time is your flight?
It's 10.
Okay, you're fine. Okay. And Orajitt is going to Singapore, so we go. To speed this up, the first question we have, I'll put it to the whole panel so that we get an answer, because it's important. They say health economists, I suppose even health, the politicians know the price and cost of everything, but the value of nothing. This is something taken from Oscar Wilde, I think. Do you think that this once-in-a-generation opportunity of investing in genomic and digital healthcare, in this consideration, we are bickering about the price and cost, but not the value for mankind? Is it similar to two fleas arguing who owns the dog? To start with value-based healthcare.
Yeah, I think that's a really big question. When I read it, I said, well, we're going to need 1 hour to answer that. But no, I think, yeah, everything, every field, not just healthcare, but is moving towards the digital age. So healthcare, of course, anything that you talk about today, you have to include digital health in the conversation, because that's just the way the world is moving. And so, for example, the work that we do, everything is content, and evidence-based research and talking with the patients. But at the end of the day, when you have that, what do you do with it? How do we look at all of the hospitals that we want to work with? How do we look at all of the outcomes that we're measuring for patients, and how do we compare it? All we can do is look to see how digital health can help us to get there. So, for example, one of our biggest projects now is creating learning collaboratives to collect data from hospitals who are all looking at different diseases and try to compare them. So you can go manual and ask patients to respond to questionnaires and scales, and then have someone look at thousands and thousands of pages and calculate, or you can get a really amazing software and digitalize everything. And then that will, in 1 second, give you all the answers you want and help you move towards better care in a day rather than in 10 years.
Dalia, your response to that?
I guess I totally agree with Paula. It's kind of the way forward. Sometimes you feel like this is, if we lose out on picking up these new technologies and new advances, I think that definitely disadvantage patients and public in general if we don't really go with the new technology. And we are seeing digital applications everywhere. We have seen it during the pandemic, that telemonitoring and telehealth in general has been very important to get us through that stage. So we really need to start appreciating that it's about the value we get from every pound we spend or every dollar we spend. It's not about thinking about how much does it cost, and that's how health economists actually dispel the mess about using health economics in decision making. It's not about cost cutting. It's not about always thinking about the price of what we are paying, but it's about the value of what we get. It's about maximizing how much gain or health gain that we can get from the money we are spending. So allocating resources wisely across sectors, and I think new technologies that offer these values, we have seen it come with all advances in medicine and healthcare in general. They do come with a ticket price, if you like, but we need to be able to assess their value and make the decisions based on that, rather than thinking about how much do they cost, how much added value they give to our population.
Thank you much. And Diego, same for you.
Yeah, I think that is a great opportunity in order to invest in all related to digital healthcare and all the resources that can provide information in order to define the best price and cost. However, I think, and I want to remark that the participation of patients and citizens are very important in order to determine the value of the health technology, because they, in some cases, the information is not it's not about numbers. For example, it's not metrics. Maybe it can be quality. Some information that is different, qualified information maybe, but it's very important because the results that are expected in the implementation of a new technology are known by the patient, by the caregivers, because they know how the impact of the new technology can be affect their patient journey every day. So I think that the best option is to invest in this kind of things of participation on to get this kind of information in order to define the value.
Thank you, and then to you.
Sorry, you're talking about the
Yeah,
digital health, right?
Yeah, on both genomic medicine and digital health, both combined.
Yeah, that's also very important, especially those high-cost patients and rare disease patients. Right now, they also need diagnosis and consultation much more, and this digital health and also help them. But sometimes they need to meet the doctor for diagnosis first. And after that, they can have a digital health and they can get medicine from the pharmacy also in Thailand, especially during the pandemic. Like those high hemophilia patients, they need the factor 8. It's already included in the benefit package of health security system. So they can get the factor 8. From the hospital, and also no need to come to see the doctor.
Okay, thank you very much. I'll just add a comment here. This is Jan from Eurodis and Rare Disease International. We were discussing this issue. We were saying that, look, if you look at it in depth, the health technologies that were used to contain the pandemic, and then also Professor Lara Bloom was there listening on this meeting with Jan at Rare Diseases International. We said if you look at the health technologies that came to the service of mankind in the end, were the very health technologies that were actually developed for rare disease patients. Adenovirus therapy was actually originally designed, Professor Vedrol and others looking at transporting genes as genetic gene therapies. And mRNA was designed to look at some of the genetic disorders with protein deficiencies. They were coding that, putting lipid and hoping that would go somewhere and on. So Jan, Lara, and I both agree that it's time for society to pay back the rare disease community. So therefore, we should be investing with open coffers, and the returns are far more than what we're investing. So that's just a passion that we were thinking about. And I think, Lara, hopefully on Monday you do make that statement. On that. My next question is to Dalia. I think the reason why I'm asking this was that our Global Patients Congress here was opened by the health minister from Kiribati. It's a small island on the universal deadline. The sun first shines there for the new year, and then the rest of us mark it. The minister for Kiribati, minister from Uganda, minister from Nigeria, minister from Egypt, minister from Kenya, Kenya is leading it, Brandon, minister from Australia, anybody from New Zealand, Canada, others are meeting today, at this very same moment, in the Commonwealth, just at the Hilton Hotel around here, the back end of it, and saying, let us restart, rejig the universal health coverage. The question is this: in your opinion, is HTA and UHC marriage the most perfect marriage for low and middle income countries right now when they're considering of reviving universal health coverage? Or should they go look for something else? Yeah. Thank you.
Well, in my view, to be honest, I think that's the only way forward, because if you are going for universal health coverage and trying to provide that service that caters for everyone in the population, then you need to think very carefully about where you are spending your money, what services you provide. Because there's no healthcare system in the world that can afford to pay for every single technology or medicine or new intervention that's out there. So unless you're able to think carefully about how you allocate these resources, and actually justify this to the population, be able to show that you've taken these decisions using a very objective, transparent, evidence-based approach, you will not be able to get everyone on board and accept your decisions. And I think that's the only way. I can't think of any other non-HTA based approach to be able to allocate resources effectively. And that's for low and middle income countries. I know that some countries think that we have already enough budget to cover, and maybe HTA is not suitable for us or is not required for us. But if you cut down and go through their healthcare system, for example, you will find that they have, for example, private insurance, which is the other side of the equation, or the other model maybe, that's not universal health coverage or state funded. And the health insurers themselves, they need some sort of a tool to help them decide what's in their benefit packages. They don't provide everything, even for countries that rely on insurers. In my view, it is an objective tool to think about how much value you are getting for every pound you spend and allocating your resources effectively. And that's the only way to maintain the sustainability of universal health coverage. I can't see any other way, to be honest. It's about how you then maximize your funding or your budget for healthcare that can help you with maintaining that. But with any level of budget, you need really to think carefully about how you allocate resources.
Okay. Thank you very much for that. I think that's good. Now I'm going to the last questions, and we'll bring. This is for everybody, and this last question is, I think, core of it. One of the aims and objectives of HTA is that it's about societal values, and I think one they've said is, whether it's implicitly or explicitly sometimes, that HTA is there to boost social inclusion and reduce health inequalities as part of the aims. What are we doing for one in Europe? I'll start with the ICHOM on the side. Say the high hill farmers in Wales or maybe in the Pyrenees. Then for the Egyptian sort of WHMRO, some of the migratory groups like the Tuaregs and Bedouin groups. In Latin America, the indigenous peoples, and in Thailand, you have your community groups there. How are we including them in HTA and bringing them up? Who wants to start first? Go ahead and take it for you.
Okay. Social inclusion is very important for the whole world now, especially in rare diseases. We in 2021 was adopted a United Nations resolution in favor of rare diseases population, and this resolution promotes the social inclusion beyond the access to health services. It's important to work on that. In Latin America, we are working together with the different countries in order to promote health national plans focused in the social inclusion. In case of indigenous people, we have an additional challenge because the indigenous people have been facing things, for example, social determinants that have a very important impact in their health conditions. For example, the access to water, the access to education, access to different things that are very important to them. And we have to promote the participation of this community, for example, taking into account that they do not, in case of Latin America, they do not speak, most of them do not speak Spanish or Portuguese. They have to be access to some resources related to HTA, but in their mother tongue, and we have to provide information, useful information in different resources. They don't have access, for example, to smartphones or internet connection. And so we have to face the challenge to include didactical and educational resources that can provide the useful information for them in order to promote their participation in the health technology assessment.
Thank you, H. Orajitt, your opinion?
Yeah. It's also, this is a challenge question, and good that you raise it. At the moment, we're talking about how to include the vulnerable group or even the disability group or those rare disease group in the HTA process. But since we have as I told you, we have patient network representative, and they work together. So no problem if even those vulnerable group or disability group, they can't join because of physical, because of some economic, something like that. We have representative to sit in the process and talk for them and also feedback.
Thank you. Dalia, for you and I always crisscross London, and I know you've seen that diversity of London. There's a model presented by one of the ministers. It's called the Jubilee Line model. This is the train, it's called QE something, Queen Elizabeth Line or something. It travels from Westminster, where the average life expectancy is X, whatever it is, it's in the 80s, 90s. But every station it passes on to Canning Town, 1 year of lifespan is reduced until it's full 10 years below the region. This is the health inequality within London. In your opinion, are we included the marginalized community, minority ethnic groups, and others in HTA? I know it's got a good model. I'll allow you to say it.
No, I think that our process, in terms of NICE process of patient and public involvement, is really open and inclusive to everyone who's affected by the decisions that are made. We provide support to all communities to be able to engage, and I mentioned some examples of being able to join, for example, remotely if you are unable to travel, if you are disabled patient or affected by any of these conditions. Potentially also I'm from a minority background, and I think it is the opportunity for people from backgrounds that are maybe not speaking English that much is still possible for them to understand and contribute by having some patient. Our NICE style, for example, in writing takes into account that levels of literacy and the importance of having the language to be suitable for the level of the lay members. And we always get this very carefully checked accessibility also for any documents that we produce. So I think generally nobody does everything perfectly 100%, and there's a scope definitely for improvement, especially given the level of diversity, and as you say, in London. But I think there has been many efforts to try and think about how we can make it possible to be inclusive and diverse.
Now, the last question, I've deliberately reserved this. This is my payback to my mentor, Professor Michael Porter. This goes way back when I was doing my MBA, and I think I owe him one now. I'm reserving it for you. Can you tell us, what are you going to do at the Barcelona conference that you're holding? Tell us more about that. I have to plug your conference. How are you going to bring us in there to discuss value? Over to you.
Okay, again, a big question. And as I said when we spoke before, I will try to channel Michael Porter as best as I can, which is a big feat. So yes, we have our annual conference happening in Barcelona in October. And I think our last conference was 10 years, what have we done so far? And this conference will really be, what are we doing now, as you asked? One of the biggest points, as I already talked about, is digital health. How can we, so we've created all these stats, we've defined what do we need to do, does it work? Yes, it works, but now we have to make it work, and now we have to bring it to the whole world in a way that actually makes an impact. So actually in their conference last year, somebody made a question, well, a comment more than a question, and said, this feels more like a tech conference than a healthcare conference. And that may be true, but what we're doing now is trying to bring the content digitally to the whole world in a way that will impact patients the most. So I spoke about our learning collaboratives. That's going to be one of our biggest topics to talk about. Our learning collaboratives are now networks of hospitals who want to implement this system and who want to work with patients to improve patients' lives and to benefit their functioning as well, to improve quality of care. So we're going to talk about learning collaboratives. We're hopefully going to talk to people who are interested in becoming part of our collaboratives, work with us, implement our sets, and really have an impact. I don't know if I've answered the question.
Yeah, thank you. You've done that. So thank you, everybody also who joined us online and supporting us. Any other questions we will be answering back later. I must thank the panel for having really helped us see the pure picture, and I hope it inspires you to get involved in HTA. Now, before I let you go, I just want to announce a little change to the next session. We're combining that. We'll have a coffee after it, but it's going to be a short session we are holding. Most of the NSAs, as you know, turned up today. As usual, the WHO is a little bit rusty at the moment. They've all had to rush back and try to get those statements re-agreed and re-put in. But I will share with you where you can find out what the town hall meeting, a virtual town hall meeting practically now going on, where they're now posting their viewpoints. And you can have a look at all those who were present here for 2 days, what are they saying at WHA. So I'll thank the panel if you can exit, and then I will ask Manish to change over to the NSA website. I'll quickly go through it, and you can then look at it in leisure and see how the elephant is going to be described at the World Health Assembly. Thank you.